Thank you, Annie, and thank you to David and Prof Oendal. It's a lot of things that I didn't think about myself that I heard and or relived, and I wish my parents were here. My father would certainly have liked what you said, and I think my mother would actually have believed most of the stuff that you said as well. So Annelies asked me to speak, and she sent this title, and the title was a reflection on a career. So this is very much a... Yes. Okay. Sorry about that. Okay. So this is the title that Annelies gave to me, and I kept it as it is. And this is very much a story of our experience the past more than 30 years in the department. And I was thinking of something that I remember as a kid, and that was the white hair of Alice in Wonderland. Was when they told that he should give a speech. And he was very upset about that, and he said, now where will I start? What will I say? When will I stop? And the answer that Alice gave him was, start at the beginning, say everything that needs to be said, and then you stop. So that was really what I had to do. This is very much a reflection of the career that I had here, starting as registrar in 1986, included there the research fellow at the University of Dundee from 93 to 94. And all the other things that happened to me over the time that I was here. I'd like to go back before the start. As I was here as a third-year student, we had to do 20 deliveries, and we spent 4 or 5 weeks in obstetrics. I can't remember exactly what. And at that time, there were very few, or relatively few, registrars, and in many obstetric firms, there was a medical officer that was head, and we were a person that was quite difficult, to such an extent that I disliked obstetrics. I thought if obstetricians are like this person, I wouldn't like to do that. But then came the 6th year, and it was Christa Bernardi, was our registrar, and Christa was a person that would take you, we'd both scrub up. In those days, we scrubbed up for just about any procedure, and she would sit there and hold the forceps or the vacuum, and I think we thought that we actually did the vacuum. But she gave me a new perspective of how nice it is to be obstetrics, to do obstetrics. I was a husband. We were spending the 12 months that we did. There were 4 months in one department and then 4 other rotations of 2 months each. So I spent 4 months in obstetrics and enjoyed it very much. And then I went to the army. I was sent to the Eastern Cape Hospital, and I landed up in Alice, and they asked me, have you done some obstetrics? And I did the obstetrics, and then suddenly I realized that most of the simple things that happen at a small hospital, I was able to do. To such an extent that while I was in the army, I decided I would like to eventually do obstetrics and gynecology. And I came back. Professor Oendal was in Bloemfontein at the time when I was a student, and he came back when I was in the army. So I knew Prof Cronje very well. I came back to Prof Cronje and I said, Prof, I'd like to come and do obstetrics at some stage. What should I do between now and when I come back to actually do that? And Prof Cronje told me a lot of things. He said you should do medicine, you should do pediatrics, you should do anesthetics, you should do surgery, and you should do urology. Because if you do those 5 things, you will learn a lot of stuff that you need to know when you want to become a registrar. But he said, go and speak to Prof Oendal. And the purpose of that meeting with Prof Oendal, he said, would be that if I come back in a year or 2 later, Prof Oendal might remember my face. So I walked in there and got the appointment with Prof Oendal. I don't know if he remembers that. So he asked me, what do you intend doing now after you've done your army? Because I don't have a post for you immediately after you finish your army. And I told him about these 5 things that I need to do. And Prof Oendal said, I don't know where you heard that, but that's not necessary. Because we're going to teach you all that stuff when you're here. So you don't have to go and do urology and all the other groups of things. So I came back in 1985, and I was working with community medicine with Prof Wicht at the time. And at that time, I started learning for my primary, because what I should also say is that when I came to Prof Oendal, they said, please excuse me a minute. And he came back with 5 books, and he said, these 5 books are the books that you need to study for your primary examination if you're serious about that. And David actually spoke about me being on the Gullis and going down to Marion Island, and those books went with, and much of my studies for the primary exam actually happened on the boat near Marion Island. Then when I became a registrar, I started off in the labour ward, as most of us did at that time. It was 24 hours calls. I started on firm 5, and those of you who know the old system will know that that is the Friday nights that you did. So it was particularly, I remember so well. The 1st of January was on a Wednesday, the 3rd of January was a Friday. And we were sitting there, and sort of like around about 3 o'clock, everyone just went away, and you were left alone with 2 junior doctors to actually do labor ward. The labor ward was quiet at the time. I remember there was some belief that if you make a lot of noise, people with preeclampsia might get convulsions and so on. So the areas where the patients were lying was dark, and only the passage had a light in. The other thing about the labor ward was the punctuality. Round started at 8 o'clock, and we kept along that. Labor ward is big fun to me. I really enjoyed labor ward to such an extent that I was looking forward to the next call. I remember we used to deliver breaches, and in all the time that I was in labor ward, there was just one breach presentation that I actually had trouble with, and that was a patient that, if one has to be frank, she was totally drunk when she came in. She pushed, and the baby's body was born, and she passed out. And she was just lying there, and we had to deliver the head. And we got the head out without any problems. We thought that this, looking at his mother, this baby is probably going to be good for throwing stones, but we weren't sure whether he'd be able to throw them in a straight line. We also did many forceps and vacuum deliveries. In those days, we did deliveries, assisted deliveries for things such as previous cesarean section, often cardiac lesions. And I also then learned how to use the Piper forceps, which I think is a great forceps because you've got the baby already being born apart from the head. You use the Piper forceps in breech presentations, and it was very easy then to apply the forceps to the head, and it was just like a small movement to get it out. At that time, we had to phone for all cesarean sections, and I remember Prof W was saying at that time, I remember we were once at one of our meetings overseas, and he said that we actually have a double control system to make sure that we don't do unnecessary cesarean sections, because the registrar has to decide, and he's got to be ready to actually defend it. This cesarean section he intends doing, and then the consultant would actually okay that. So there was a double control for that. Many funny things happened in labor ward, and there was one particular thing that I would like to just recall. It happened on a different call than my own, and two patients came in at the same time. And one of them was actually a twin presentation, and in those days, all twins were delivered in labor, in theatre, and with everyone scrubbed and ready to actually proceed with cesarean section for the second twin should it be necessary. And on that particular day, they mixed the 2 patients. And the patient with a singleton pregnancy actually landed up in theatre, and the twins was put somewhere in a ward where she delivered without any complications. But there was something in those days that the ultrasound machine was not, I think, nearly of the standards we've got today. And I remember that particular ultrasound machine that we had more stripes, and you could actually see the picture as such. And apparently what happened is this baby was then born in theatre, and they were looking for the second baby, and someone came with an ultrasound and says this baby's heart is extremely slow. And they proceeded, and there was argument later on whether it was a cesarean section or not. They proceeded with the attempted abdominal delivery of this second baby, and the only thing they found in the uterus was a placenta. So someone said it wasn't a section because you've got to take a viable baby out of the uterus for that reason. And then it all apparently happened very quickly, and then someone said, has the patient signed consent for this? And they said, no, the patient hasn't signed consent for this operation. Unfortunately, in those days, we had a system where people thought that the husband also had to sign consent for sterilization. This was done beforehand. So they went into a folder and found this form where she signed for sterilization, and the husband also signed. And they did the sterilization. And the funny thing was when they then the next day, when the patient was awake, told her about what had happened, she said, well, I came here to ask you, when do you do sterilizations? Because I don't want any more children. And you said it's usually the day after delivery. And I said, but I'm so serious about the sterilization, can't you do it immediately after I delivered? And when you rushed with me into theatre, I thought you were just sort of complying with my request, and there was no consequences from that happening. Gynecology was also nice. I loved oncology. I loved the way that Gerrit Lindekie taught us. And at one stage, I was actually wondering whether I shouldn't do oncology once I finished. Infertility, I think I did too early in my career because I've only done 2 months of gynecology before I went to infertility. And I don't think one really does have the appreciation for all the stuff that's important at that time. The other thing that I need to say something about was the PAL. We went to PAL for 3 months, and Dr. Paul de Villiers was there. And I don't know if it ever came out with Professor Odendaal, but Graham Howard was there before me. And when he heard, or when Dr. de Villiers heard that the registrar coming here has got only 2 months of gynecology behind him, he told Graham to tell Prof Odendaal he must send some other registrar, which didn't happen. And Dr. de Villiers was on leave. So I got into Paul, 2 months of gynecology behind myself, and he was away for the first week or two. And when he came back, he actually said hello, and he said, I heard things went very well. There weren't any maternal deaths. So it was quite clear that the test for me was whether I could prevent maternal deaths. Interesting thing about, I can say a lot of things about Paul, but sterilizations on the weekend, what we did is we actually took the patients the day after delivery, and we did epidurals ourselves, and then actually did this sterilization with the patient under epidural. And it all worked very well. One of the highlights there was the set of Siamese twins we delivered there, baby with 2 heads really, which actually, the baby died a short while after that, but it was a section that we did, and I always remember that case. Then I remember one day we were standing there, and I remember this is back in 1987, and termination of pregnancy was illegal at that time, and we had a young patient in the ward, 12 or 13 years old, being pregnant. And Dr. de Villiers told those of us standing with him at the line, just yes or no, are you for or against sterilization? I said, I'm against sterilization, terminations, I'm sorry. And he said nothing about that. We just went on there. Now, what I know is that all registrars who worked with Dr. de Villiers got invited for a steak towards the end of the block there. And I wasn't invited for the steak. So I was wondering why that happened. And then I went back to Paul twice after that to relieve some other registrars. And then one day, Dr. de Villiers said I must ride with him up to what's it, Parel Oos? But in any case, to the hospital where we did our clinics, and he told other people, you can't drive with us. So the 2 of us went up, and he told me sort of a funny story starting off. I was sitting at Johannesburg Airport the other day, and I drank a beer. And I wasn't quite sure how to respond to this, so I said, listen, I was there some time ago as well, and I also drank a beer. And then he said, do you drink beer? I said, yeah, I drink beer. And he said, do you drink wine? I said, yeah, I drink wine. And he said, well, I want to ask you for a steak, because several years, or when you were here the previous time, I asked you about whether you're for or against termination, and you said no, and I decided you're a very conservative person. You will never drink wine in front of other people. And I couldn't see myself eating a steak without drinking wine, but while you're willing to actually drink wine, I'm going to take you for your steak. So I eventually did get my steak. What was also important of my time as a registrar, and it was something that I think to some extent influenced my career more than I thought at that time, is I was taken by Gerrit Lindekie to a congress in Pretoria. I did my research on second-look laparotomies in ovarian carcinoma, and there was a Dr. Tinus van Staden. And he was at the University of Pretoria, and we just spoke, and he asked me what I intend doing, because I was now sort of towards the end of my registrar career. And at that time, I think it was almost that he said, I don't know, I'm not quite sure, I don't have a plan yet. And he said that when he became a consultant, he immediately went out. He worked in private practice, and he was always wondering how it would be if he stayed on. And then he said he came back for the last 5 years of his career to be an academic. And he landed up in oncology, and he said the very first time he saw the registrars, they asked him, why don't we have a nice laser machine in Pretoria? And he didn't know what the laser machine was. So he told me that if you aren't certain what to do, stay on for about 5 years, and then if you want to go out into private practice, there's still enough time to do that. And I'll get back to that just now. The examinations of those 7 people that you had on the picture there, David, I was the only one that did the college exam as well, because in those days you could either register with the college or the MEd registration. My college examination was at Medusa. And there was a lot to say about Medusa, and I'm just going to briefly refer to 1 or 2 of the things. I got a patient in obstetrics with a cardiac lesion that was on warfarin and was changed back to heparin, and that was why she was admitted. And she came from the far northern part of, which is now Limpopo, and I was, there was a sister or a staff nurse actually asking the patient questions, and I'm asking her the questions, she asked the patients and then translated to me. And then the staff nurse had to go out, and the patient said to me in pure Afrikaans, she said, "That woman is not telling you what I tell her to tell you." Okay, so that was a bit of a problem. So I said, "Okay, quickly tell us about what it was." And then Professor Sonnendekker was actually the examiner. And Professor Sonnendekker came in and I presented the patient, and he said, "What is this patient's biggest danger?" And I said, "She might bleed or she might clot." And I went through several things and I couldn't, he just said, "No, no, no." And Professor Basil Bloch was the other consultant there. And then eventually, fortunately, Professor Bloch said, "Professor Sonnendekker, you must tell us now what it is, because I don't know what the answer is either." And Prof Sonnendekker said, "We, doctors, are the patient's biggest problem." Okay. And then we went to gynecology. Gynecology went very well. There was a patient there that when I asked her, she could speak English. And when I asked her why she came to hospital, she said that her employer got a letter that she had to come to hospital, but she wasn't sure what about. And then I sort of made the mistake to ask her, "Are you coming in for hysterectomy?" And she stood up and says, "I'm going now." I told them, if anyone else asked me in this hospital whether I'm here for hysterectomy, I'm going to go home. So I explained to her, "I'm from the Cape, I'm not really from there, I'm just asking." And it landed, then one could work out that she had an abnormal smear, and it went very well with discussion thereof, and that was the Professor Makogong and Dr. Gordon Grant. And at the end of the case, Dr. Gordon Grant said, "Remember, there's still oral tomorrow. Don't drink too much tonight." And I sort of told him that I don't drink, you know. And he said, "But don't drink too little either, you know." So that was very nice. So oral examination, I landed up with 2 oncologists, Professor Bloch and Dr. Gordon Grant. And I remember at that time, Prof Oudendal, there was talk about whether we can add a second antihypertensive drug to patients being with preeclampsia. And I don't know exactly why anymore, but I went through the literature at the time, and I decided if someone asked me about that, I'm going to say monohydralazine will be the drug of choice. So they asked me, "Can you tell us a little bit about early onset preeclampsia that presents there?" So I took a side, didn't want to look too excited about this question, and started talking. They never stopped me, up to the point where I got to, if we have problems with their blood pressure control, we might add monohydralazine. And that was the first response I got from them, and Dr. Gordon Grant said, "Remember, she's pregnant, will you really give her a second drug?" And Prof Bloch said, he's one of Hein Oudendal's boys, they actually give second drugs at Tygerberg. So that was nice. The MEd cases I got, okay, then I came back, having passed the college examination, and there was such a confidence over you, there was no real need now to pass the MEd anymore, in the sense that you didn't worry about what they're going to ask you. And I actually got a patient with a severe growth restricted baby, and I got a patient with a vault prolapse. So then eventually I became a young consultant. And I was saying this because Prof Oudendal was only come back from Louvain, I think 6 months, June or July that year. And I was working with Bob Pattinson. And Bob Pattinson asked me, "What are your plans?" And I said, "Well, Dr. Tinus van Staden said, I'm going to stay here for 5 years, and then I'm going to see what I'm going to do after that." And he actually said, that's good, but then you should start working now as if you're going to stay forever. Because if you're going to stay for 5 years and don't do anything and then decide to stay on, then you're 5 years behind yourself. And I was getting involved in research and other stuff. I was at special care where Bob also told me that you will not always succeed. All your patients' babies won't survive. He said, unless you're the best doctor in the world, which is unlikely for any one of us, or unless we overestimate the severity of the disease of the patients that we see there. So we will get setbacks. I also learned a lot about statistics from Bob and some other things. And then Prof Oorndaal returned. I was with him on the firm. Bob left for Pretoria at some stage, so we had 2 consultants on firm 1. The special care, once again, Prof, the rounds that we had in special care were so informative. You know, you're standing there discussing patients, and there was also something new that Prof thought about, things that he said, and there's some things that we do today that I can remember actually happened or was discussed at the time of those rounds. One of them being that we were giving our patients with severe preeclampsia managed expectantly. They got steroids every week. So some of them got 5 or 6 doses of steroids, and then came through saying that you shouldn't give so much steroids. And people said you should restrict it to 2 dosages unless you actually doing a study. So those were the first dose, and the other one 24 hours later. And the new Prof at that time said we should perhaps then do that, but we'll give another dose a week later. And that dose later on became known as the rescue dose. Also gynecology at the time, we the preoperative rounds, all the consultants, or at least the 2 consultants that operated, went. So I learned a lot from Prof Oorndaal there as well, because the patients got presented by the registrar, and then things were discussed, what are the possibilities, what are the alternatives, and that was a very good learning experience from a very experienced surgeon. And then a talk with Prof Oorndaal, he probably won't remember, but he took perinatal mortality unit for a lunch around about Christmas time, and we went to Spier. And Prof said he thinks there are 2 things that I should do. The one thing is I should do a D, and the second thing I should go overseas. And from then on, we started working in that direction. So that talk was very important in my life as well. We stayed on 2 consultants per firm, and then I went from firm 1 to firm 3. I was also head of firm 5. And on firm 3, I remember, Stefan, you left at some stage, and then I was left alone on firm 3. The 2 of us were working together for a year or 2. I can't remember exactly how long. And then for 3 months, I was alone there. And I did all the things that consultants had to do then. The most difficult thing was actually the clinics, because in the clinics, you just can't, as a single consultant, do students on both sides. You can actually operate, you can do 2 rounds a week, but you can't do that for the students. So fortunately, Herkie Sandenberg came later on, and we were back to 2 on that firm. Continued working with special care. And then this is something that Prof Oorndaal referred to, and to me this was also one of the highlights. And I remember every Tuesday we had this unit for perinatal mortality meeting, and as Prof said, the obstetrics and perinatal protocols were discussed, all the results were discussed, and in the end we had a very good idea of what was going on as far as research is concerned in the obstetric part specifically of the department. I learned a lot about the research methodology. Prof Oorndaal had extremely good knowledge about the different methods. I learned a lot about statistics, and I also went to the Cochrane Center. Jimmy Volmink was working there at the time, and I actually became a Cochrane reviewer as well after having attended those courses. Then the undergraduates, obviously we spent a lot of time with them, and this is sort of like my time as general consultant. There were originally small groups. There were 2 students, later 3 students, later 4 students. We were wondering, how are we going to be able to cope with this ever-increasing numbers? We had the 12 o'clock discussions at that time, and at that time the head of department did all the discussions. So I can't remember which day of the week, but every specific day of the week I spoke to them. And there were lots of incidents, lots of funny things, lots of things that are memorable, and I thought I'm just going to mention 3 of those. And I remember one day we were standing in labor ward, and there was a patient who ruptured membranes very early on, let's say 26 weeks, I can't remember exactly. And we asked the students, now, what are the dangers? They told me about pulmonary hyperplasia, they told me about infection, and I was wondering whether, what else I could think about, and what is toch when they are lying in the uterus for a long time and they sort of like get a different form as they were lying in there, and they got contractures. I couldn't get on the word now. So there's one student left. I always had the habit of asking each of the students. So I told the student, if that cupboard there, if we now take you and we put you into that cupboard, and there was a small area at the bottom, so you're sitting like that, and we're going to leave you there for several weeks. And through that hole, we're going to give you food and water. What do you think is the biggest problem that you can develop? And he said, meconium aspirations. There was also a story about the vaginal examination. I was very uncertain whether I should mention it, but I saw that, remember in those days you saw the students in the wards, and then you saw them in the labor ward as well. So we were talking about stretching membranes and as a method of induction or assisting in the method of induction of labor. And that same group went to the labor ward later in that week. And there was a patient who I thought she would benefit from stretching the membranes. So I asked the student, remember we spoke about that the other day, what would you do for this patient? And he said, I would do an aggressive vaginal examination. And for many years, there were mostly males in the labor ward. I could tell them a story about the aggressive vaginal examination, but nowadays I think it wouldn't be the right thing to do. And then as the groups became bigger and you had students for 3 weeks, you sort of realize who's the most clever of the students. Very often you could see that's the best students, that's the second best, and so they go on. And then what happened if you ask a question, the best guy usually answered first, and then the second best answered, and the third guy answered, and then the poor guy who was left was the guy that wasn't as good as the other three were, and the other three have already answered the easy question, so he's now stuck with a difficult answer. And I remember one day we were talking about expectant management of severe preeclampsia, asking them what would be fetal contraindications. And they more or less said fetal distress, fetal death, and although preeclampsia doesn't necessarily cause abnormality, but if you've, for instance, got a baby with an anencephaly, you wouldn't be expectant either. So those three answers came very quickly. And I was on the point of telling the other student, I don't think there's another reason. Reason for not being expectant. And he came up and he said reversed end-diastolic flow velocity, which was quite important because the Americans often say that growth restriction is a contraindication to expectant management. And if you ask them, what is growth restriction? How do you define that? The answer would be something like, you're an obstetrician, you don't even know what growth restriction is. So I never got a good answer from any of the Americans about what it was, but suddenly this guy that had all the other questions wrong gave me this answer that I think was very appropriate. Then there was the part where I became responsible for teaching. I remember the reproductive system. It's interesting, we're working on a totally new curriculum now, but that was around about, I think, 1997. They were also starting a new curriculum, and the reproductive system came up. And I remember there was a need to actually decrease the number of lectures because we were giving too many lectures. And things such as cardiac disease in pregnancy would often be given twice during the obstetric block, and then once again we were asked to give the same lecture during the cardiology block. So Prof Undal told me at that time, you've got to cut the number of lectures by 20%. And I was able to do that, so we got up the reproductive system. We had different people helping us, and I remember Luke, David, they were all, I can't remember, Stefan was also involved in, but they were writing outcomes for different groups. And there were some people that just didn't do it in time. So of the reproductive outcomes, there I think are too many of the things that I've written. And in the time since then, we asked people, Gerritron also wrote, we asked people to actually revise it and see whether it's actually still appropriate. And I remember it was only David and Lutz and Gerrit that let me know they wanted to change it. So I think some of those things are still the way we started 20 or more years ago. Then we got the student interns in Worcester, the longitudinal rotations. There was a long discussion. We went through to Worcester quite often. At that time, Prof Wynand van der Merwe was the dean, to discuss how we would do this. And And I was involved there from the beginning. The Uppington group then came. I wasn't that much involved in the Uppington group, but it also happened. And then last year, the Ideal group. And I'm not quite sure exactly what the Ideal stands for anymore, but it's the 5th years, which now, because of COVID, in the latter part of the 5th year, they went to the countryside, or not countryside, they went to different hospitals. And as a result of that, the rotation with us was cut down to 5 weeks. So I was also responsible for the obstetrics and gynecology part of that course. The Tygerberg student interns I took over from Prof Steyn. It's a long time ago. That was more or less at the time when they went from long cases to the OSPE as it is at the moment, and I did an analysis of the results quite often. And it was quite clear students did the best, then the consultants, they for OSPE stations, and they did, initially did much poorer there, but now they're picking up and they're also getting good marks there. But our students can't write. And so the 5 stations that remained where they wrote, they did very poorly in those stations. And we did things such as adding a second station before the partogram and the antenatal card to see if the time was the problem. But we were looking quite well at how this course worked. And then I think you all know about the knows how, shows and does. And what is something of a problem to me with the OSCE is that it was in the registrar stations where you had to show. You had to show this is the way I examine the abdomen, or this is the way I pass a speculum. And the consultants didn't ask people, the questions of the consultants weren't such that we show. And I spoke to Gerrit Tron about that, and he actually thought that there's a bit of show in the way they answer the OSPE stations as such. That is a problem. That is where you go out and you're on your own. So this is basically what you do once you've become a doctor and you go and work in some other place. And I tried to bring something of the mini CEX into that, and it just never worked very well, because the mini CEX in the portfolio, those are the 2 places where you can actually test DAS. Sunderland came, that was very nice. Sunderland is a very nice program. You can actually use it for a lot of aspects. You can also analyze your results very nicely. Then we got to the promotion idea, which happened a few years ago. It's because of the increasing numbers. I think there's no other real good reason why we decided to have a promotion, but to prevent those massive exams in April and November, where we just couldn't do anything anymore. And we started, you all know the requirements, I'm not going to repeat that now, but if you had a specific score, average above 60, including 60 in your final year, you got promoted. So you passed without doing an examination. And I'm not quite sure. I think that has made the examination, or making the possibility of getting marks much easier. Because last year, I think there were 128 distinctions. That's a lot of distinctions. We were always working between 6 and 8 or 10 distinctions a year. And so I think that's because we took out the written stations, which is stations where you really got tested. So we left the students only with the 2 groups of stations where we know they're going to do well. And then the early and the mid-clinical block, they contribute a significant amount to your final 6-year mark. And the people do extremely well there. I've actually had to look now. You all know the requirement is you've got to get 60% in your 6-year as well if you want to promote. But if we leave that out for some time, there are people who have already passed obstetrics gynecology after the first 2 blocks. If you add the early and mid-clinical together and you take the average, they've got more than 50%. And I think that's something, Heinz, I think in this week, was it last week, and you suggested that we got to get a committee that looks at the whole group, or the totality of the undergraduate training. We should perhaps just address this, because clearly you can't change this in the middle of the block. You'll have to decide to change it in a new year if you want to make some changes. But I'm not so quite sure if we've got the ideal situation with our current assessment. What I did in Tygerberg Hospital, I can go quickly here. I was working with pediatrics. I was for a long time the rep in the dispensary. I was went, I think Prof also referred to that, to represent the head of the department, day management and so on. And then just a little bit about the labor ward. I'm not sure if I've spelled Sister Bredenon's name correctly there, but Sister Bredenon was in charge of the supplies in labor ward, and we worked together very well. And I remember the cardiotocographs. When you got new cardiotocographs, we always tried to put the requirements so that only a Hewlett-Packard would qualify. And she didn't like that because she said their paper is very expensive, and so she always gave me grief about that. But we managed to get Hewlett-Packards for a very long time. Then the replacements, I also learned that if you go to people, because sometimes you get a CTG, and the CTG, when you press the button, there's a little red light going on, and then the people would say this CTG is still working. So it was very nice going down. Mr. Radain was the person there at the time, and going down and saying, listen, we're trying to see the variability, for instance. And if we can't see doing that, and that's why we need a big screen like the Hewlett-Packard has, then we don't really know what it is. And Mr. Radain very often actually gave us the new equipment we acquired. So in Boston University, I think Prof also referred to, I was also secretary for a long time of the consultant committee, taking notes there. I did several other things. The MCC isn't really a university part, but Bernard van der Wal got me into that, and for a long time I was doing assessments of new medical drugs, and several of the stuff that we use nowadays I had to assess at the time. And then I was in all three the major university groups, the ethics committee for a long time, the undergraduate committee not for that long, and then the postgraduate committee, which I am still a member of at the moment, and someone will have to replace me. And then obviously I was a member of the faculty board. I was also a member of the Senate, as all of us become professor, and there were three rectors at the time that I was there, Professor Brink, Professor Wortman, and Wim de Villiers. And then one of the best years, I think, that we had was actually in Dundee. And I remember Bob was the previous guy that went overseas. He went to Oxford, and Bob told us that the Oxford people were very stiff, and they were very polite, but they weren't extremely friendly. And he said that they were only invited once in that year to actually go and have a meal with people. And he said, the people said, when you come and have your Sunday meal with us, and they got to the front, and when they were welcomed at the front door, they went to the table, had their meal, and then they were sort of said, thanks for coming, and they left again. So Petra and I, at the time when we went to Dundee, we said, whatever we experience there, we're going to stay the whole year. We're not going to come back simply because we don't like things. And what happened is Naren came to the airport in Edinburgh. He picked us up with the two kids, being very small at that time, and one of the first things he said, I must apologize, we're busy this weekend, we can only invite you to come to us the next weekend. And Maggie, what is our man? Rob Smith. Rob and Maggie Smith, they were both consultants there, and they actually explained to us. They said, listen, it's Monday today, because when you got to the flat was equipped as we never had it again afterwards. We just couldn't afford all the stuff that they put in for us to start off in the flat. And Maggie and Rob had a kid that was a year older than Petrus, I think. And they left a lot of toys for us. So we walked into a fully furnished place listed called number 46. And on the Monday, when we met Rob and Maggie, they actually explained to us, on Monday night we're doing this, Tuesday night we're doing this, Wednesday we're doing that, so we can't invite you over before Thursday. So we went over to Thursday. We were uncertain exactly what to expect, and we said we'll see where we're going to, if they invite us in at the front door, what we're going to do. And then what we said, Lisa was 1 year old, we will tell them Lisa's got to go to bed if we're not sure whether we should actually now go home or not. And Rob, we got in there, they took us and they said lager or a pint, and we had a nice beer there, then we had our meal, and then he said, if you're in Scotland, you must drink whiskey. And the second thing he told me that was also to my detriment in the long run was a good Scotsman will never add any water to his whiskey. So we were drinking the whiskey there. And then I sort of said, this is now time, Lisa has got to go to bed now. And Rob called Maggie, said, Maggie, take her to the room, she's got to go to bed now. So we're sleeping there. And around about 1 o'clock that night, I said, well, I've got to go to bed now. So that was the way the Dundee people were. Just about every consultant invited us over. But it was also very interesting, when they did invite you over, they sent a taxi to pick you up. And they got a taxi again to take you back home, so that because they were very strict on drinking, on drinking and driving, and they would then do that. The Patels were special. At that time, he was vice president of the Royal College, and became president later on, and then later on he became a lord in the Parliament in London. And he also became Chancellor of the University of Dundee later on. And the Patels were always extremely friendly to us, not only Nairn, but also Helen. And we were taken to their parents, or actually her parents' home, and in Etzel. And she actually thought, Helen told me later on, she thought we were German. Because she said whenever she asked me, I would answer ja. And the Germans actually answered ja, so they thought we were German. And there's just not enough time to say what the Patels did for us, how they took us around, how they showed us different areas. They had a little house that they had in the middle of the field somewhere that they were renting from someone. They asked us, wouldn't we come for braai? Not the braai, what did they call it, a barbecue? And we went for this barbecue, and they actually had Vienna sausages, and there weren't chops and steaks or whatever, but that's the way they do their barbecues. I was working there on Gravidon with someone called Teresa Wilson, who was working with Mont Liggins, and I actually met Mont Liggins as well there. And Teresa would say, we shouldn't ask, why do people go into preterm labor? We should ask, why don't all women go into labor early on? And she was working on this Gravidon, and she taught me how to test for that. I actually got amniotic fluid. They taught me how to work in the laboratory, how to sterilize amniotic fluid. And the specific project I was working on was to actually look, because all the primigravida with breech presentations got cesarean section. So what I did is I went into theatre, got permission from the patient. Obviously, that's very essential in Scotland. I did a vaginal examination, did a Bishop's score, and then I took some of the membranes near the uterus and some higher up in the uterus, and we actually looked at the gravidin production there. And the more favorable the cervix was, the lower the gravidin was in the lower area. So this gravidin was certainly something that stopped us there. Now, what happened is Teresa's son was in his final year at school, and he was very much into computers, and he convinced his mother to actually go and help with his computer, and this work stopped. And there was some disappointment on the return that one couldn't continue with that in the laboratory. There were also various other projects in Dundee that I was involved in, and I'm not going to say anything about them. As far as the doctorate is concerned, Professor told you it's about the serotonin antagonist catanserin, and to see whether that actually would work, we randomized patients below 20 weeks who had diastolic blood pressures above 80, or persistent systolic blood pressures above 80 millimeters of mercury, and then they got catanserin or a placebo. And there was something built in that if we didn't get control on either the catanserin or the placebo, which we didn't know what it was, we would add methyl dopa and then go along there. And there were two components of this study, the oral catanserin study, which is what I just told you about, and then also the intravenous catanserin study, where we basically randomized patients, once again, double-blind study, and people who required dihydralazine at that time, with the randomized to either get dihydralazine or catanserin. You got a syringe with clear fluid, and you gave it to the patients, and actually the outcomes were measured. There were several publications, 6 in total, coming from the study, and as Prof said, it was printed in the Lancet. I got I got 3 invitations overseas to go and speak on this. And I really need to say very thank you to Prof Odendaal, obviously, who was the The project leader, David and Karen, who does a lot of work. Erna, I don't think many of you know Erna, and I think even fewer of you know Mariette, but they participated a lot in this. It was quite interesting. I was invited to Amsterdam to speak on cancer, and I met a guy from Janssens there who was the product manager of Ketanserin, and he was called Henk de Koning Gans. And Henk de Koning Gans told me that they're going to stop Ketanserin because it's not as successful as it is, and there's also a risk if you market something for pregnancy, because if something happens to the baby, irrespective of whether it's caused by the drug or not, people will say it's actually the fault of the drug. Excuse me. Okay, in international levels, I think there were many people that I've mentioned there. Peter van Darelson, for instance, I didn't put up because I initially thought I'm going to put up only 3 names, and we landed up with 4. But at the top is Neren and Patel. And as Prof said, they still come here, or they used to come here every year. And Neren is a Lord is in the head of law, in the House of Lords. He's an independent person. So if he invited us with Prof Oendal once, and then he also invited Petra and myself and Lisa. We were there, and we were also sitting there, and Neren was sitting in the middle on his own, and then the Conservatives were on the one side and Labour on the other side. And Neren, I found out that when I go to England or Scotland, I would phone Neren like 2 days before I come, because otherwise he would arrange things that you just couldn't do. And so, was it the last visit? I think it was the last visit we went there. He actually asked, "What are you doing on a specific date?" And I said, "I'm in Dundee that day." And he said, because the Queen, there's Order of the Thistles, and that is the highest individual recognition you can get in Scotland. And I think there's 13 or 14 people that gets elected by the Queen, and Neren was one of them. But she was able to confer this onto her own family in bigger numbers. So Prince William would then get the Order of the Thistle, and he said, "Would you like to go to that church meeting?" And when I said yes, he said, "You'll have to wear a suit." So I got my suit, took it along, and we were standing there, Petra and Lisa and myself, and the Queen came in with Princess Anne, and immediately behind her Prince Philip, Prince William, and there were 4 little boys. Wat is die ding van die rok? But anyway, this dresser was like coming 10 meters behind her, and there were 4 boys sort of carrying that along. And we were, I think, about 5 meters from the Queen of England when she came in, and she came out that same way, so we saw her again then. And they had a program then. This program is very impressive. I can't remember exactly when it started, but it would say that at 11 o'clock we do. Then there'll be a prayer at 11:03. The prayer will be over by 11:06, and they were going on, and they were actually sticking to that very, very carefully. And we saw William getting his, or becoming one of the thistles. And that was the only place, Prof Oendal, where I ever thought that Neren was something sedated. Because he was walking behind the Queen, and he was walking like a good little boy, and that confidence that you always see, there wasn't there. Gies Dekker, I became very good friends with Gies Dekker. We visited them in Amsterdam, then they went to Australia, we visited them there, they visited us here. And there are lots of things I can say about Gies. He supported me a lot with the Ketanserin study, and I'm going to leave it at that and not go further. Gerard Visser was also a Dutch professor, and I've got stacks of books because the Dutch actually print their doctorates in little booklets, and he gave me that. And he was always extremely friendly, always speaking Afrikaans or Dutch to me. And his wife, Katia Belardo, she is an Italian lady. She's very much into ultrasound, I think. And then Sabai. Sabai was also a very special person. I met Sabai with Prof Oendal in Buenos Aires in 1992. I don't know if you remember, we sat there having a beer together before we flew back. And then in 1994, we got to Sydney, and Sabai came to me. He said, "Hi, Willem, I'm Sabai, do you remember me?" So I was very tempted to say, I can't remember you at all, but I couldn't do that. And Sabai, when I visited them in Memphis, he got a big ice cream cake. And he said, this cake is for us. So it was a huge ice cream cake that the two of us shared. And we went for a steak that evening. And then one story that I think I should tell is at the time when I was in Amsterdam to present the Cathansrin study, the order of the speakers was Gies Dekker, Steyn, Sabai, and then Annemieke Bolte spoke. And they came in, and Gies was giving his lecture. And then it was me, and then Sabai after that. And after he spoke, they said, listen, we've got to bring in some more chairs. There are lots of people standing outside, so before Professor Steyn starts speaking, we're just bringing some more chairs. So that was actually also funny to hear. And then one night we were walking, I don't know how many of you know Amsterdam, and I don't know if you know where the Valle is. And that is the prostitute area of it. And it's something that I haven't seen. Petra was there the first time I actually went there as well. And you've got these half-naked ladies sitting behind glasses, and I guess you pay something and you can go in there. And Sabai, we were walking there. Sabai wanted to see us, so he took us down there. And then Sabai was very keen to actually go in. And Gies and I just said, we're not going to go in with you. And he was, I think, quite cross with us in the end that we didn't go in to actually see what was going on the inside. International studies, the Magpie study, the peer study, which David and I was involved with, Peter van Dadelsen. The World Health Organization study was a bit of a disappointment. They were looking at because they found that people, in spite of the results of the Magpie study, weren't giving people magnesium sulfate in countries such specifically Bangladesh, I remember. And the reason they said is they don't have sisters to actually look at patients who get magnesium sulfate. So they were intended doing a study where you got a single dose of magnesium sulfate to see how that compares with getting frequent dosages, and it just never went off. It was done by someone from Nigeria, and we just ran behind them. When Petrus eventually went to the World Health Organization, I believe they were still busy with this. I was very fortunate. I gave lectures or gave talks on all 6 continents apart from Antarctica, and the one in China was perhaps one of the high points. Professor Wernal sent me there on his behalf. It was actually not the ISHP, what was the other groups, the gestosis. It was, and I went there, and I was actually also welcomed there. And I remember when I asked 1 or 2 questions, they would ask me to come to the front. I knew about the Cathansrin study, and they really entertained me quite nicely there. And it was also the one place I saw that when you talk, there was 3 lights. A minute before your time was up, there was a light. Half a minute before the time, and then what they did was one of the Chinese guys who didn't stop, they just switched off his slides. So you couldn't go on at that time. And I think all of us after that made quite sure that we didn't get into that situation. Then the MPhil in health science education came up. I was very much involved in the undergraduate training, and I thought there was something lacking. I wasn't quite sure whether I'm doing things right, and I went to speak to Ben van Heerden. One morning I made an appointment with him just to hear whether he thinks if you actually do the course, you'll be a better lecturer. And the long and short of that story is when I walked back to my office, I already signed to actually do the course. And I then became aware of the idea of adult learning, where you learn because you want to know something. It's not just something that is a bit of an extra thing you've got to do. And things went very well there. I got distinctions in all but one of the subjects. And then I became interested in assessment. I became a lecturer for the MPhil in assessment and gave lectures then. Marking, it was very difficult because we're not quite used to marking papers on education, but I also did marking there. And assessment to me to a certain extent was depending on who you assess. And there were some people that I thought was quite easy to know where the level is, because if you're assessing a 6-year student, if he passes, he's going to be a houseman next year. So you could really ask yourself, would I, based on this performance that we've got today, take this guy as my houseman? And if the answer is yes, I don't think you can fail him. If it's no, you've got to be able to tell him, listen, you did this and this and this wrong, and you've got to improve there. At MEd level or the FCOG level, I think I knew at least what a specialist had to do in a hospital. I never worked a minute of private work, so I can't say exactly what you need to be a specialist in private, but I was confident in examining students because I knew what the outcome was. The MPhil or the subspecialist examination, to me, someone passing that examination should be an advisor to other consultants. It's like if I've got someone with a big mass, whatever, I go to any Wayne's and I ask them to actually do that. And because they are subspecialists, they're able to give me, as a specialist, advice on that. The MD, I think, wasn't necessarily that you had to be the best guy in that particular topic, but you should have been able, to that you were able to perform at the highest level, to identify the problem, to actually write a protocol, to do the study and then analyze it. The two areas where it was difficult for me to say, I didn't know exactly why or at what level should someone be examined for the diploma in obstetrics, and once again MBCHB 2. Because there are so many people with the repro block lying at between 45 and 49%. And I wasn't quite sure should they pass, because I think some of the people who got 50% was just lucky. He actually studied preeclampsia, while the other guy studied preterm labor and asked preeclampsia this time. So still up to this day, I'm not quite sure exactly how you decide very clearly what to do there. Assessment, I assessed at all the South African universities apart from Limpopo, and I was for 3 years the advisor to UCT after I did my MPhil. And I had to go there 4 times a year to actually attend one of their examinations and write reports on that. I also examined in Ethiopia. Little story there, we were busy. The students were all very average. They were good, passing it, and they had a very clear way of presenting it. So we saw patients with obstetric problems, and the nature was to say, this is the problem of the patient, and then examined her, and the cardiac system was normal, the respiratory system was normal, and he gets to the abdomen, and he said, okay, stop, show me what you got. And then there was one specific student who didn't say anything about the cardiac examination or respiratory examination, and I still don't know why, but I asked him, did you actually examine that? And he said yes. And then there was a consultant with you who spoke to the patient, and in the middle of us, the two of us talking, he told the student, you didn't examine the patient. And he said, no, sir, I didn't examine the patient. And the question was, do you think someone who is dishonest can become a doctor? And he said, the student said, no, I don't think so. So what they did is they said the student must fail. And I was very uncertain about that, because we certainly have got no rules in that regard at Stellenbosch. And I don't know if they've got this rule. Can you fail someone who actually lied and not get into trouble? And what they then did, they brought his marks down. And when we had a meeting similar to what we've got here, where all the consultants got together, and I said, this is why I got such a low mark. And everyone said, if you lie, you can't become a doctor. And then on the Friday afternoon, there was a meeting with the dean. And then once again, the visiting consultant gave the results. And we got to this point, said what happened, and that everyone also said, you can't become a doctor if you're a liar. So that guy wasn't allowed to pass. And then in Scotland, I examined there quite often, and I didn't realize at the time that I was there, that's the home of the OSCE. The OSCE comes from Dundee, and I was exposed to doing the OSCE there. Also examined in Pakistan, and very often for the College of Medicine. College of Medicine, I was in the council for 18 years, secretary for 12 years. Prof Van Spy, Begrati, Lindeke, and Gedotsi were the chairs at the time. And at all the various levels, I was an examiner, a convener, moderator for the diploma for the part 1. It became all bigger and bigger. I was there for about 20 years on the part 1 committee and chairperson for 8 years. And it became more and more. We went over 100 candidates, and then we started changing to developing a single best answer. And I was asked to actually chair again. But it's funny how suddenly you realize that your time is up here now, because there were many new people there, and they wanted to repeat things that we've already done in the past 2 or 3 years. And in spite of me saying we've already done that, they wanted to continue with that. So I resigned from that committee. Part 2 was a new format. Once again, I did everything. There's maternal fetal medicine. David also played a big role in the development of the syllabus and the outcomes. We changed the nature of the examination. There's talks, I don't know how far it's going to go, but that we should split maternal and fetal, that either either a maternal specialist or fetal specialist. I'm not quite sure how far that argument is at the moment, but it's certainly something to watch. Assessment in College of Medicine, I've already alluded to the changes. And then I never failed one of our own candidates. And that wasn't simply because I came from the same place that I came from. It was because they were good enough not to fail. There were one or two cases that were really very near to 50%, but they were above the 50%. And there were some very, very excellent students who registered from our unit as well. And the one that stands out is Marcel. Marcel was so good. The examination was in Johannesburg, and I think I saw her 3 times in that examination. I don't think she answered a single thing incorrectly. And it was just interesting that Marcel was 3 or 4% above the second candidate, and she got these good marks from all the students. There were also some problems. I remember specifically 2 students that I examined, both of them twice, and both of them failed both of those occasions, not with me, but they failed the examination. And it was very tough because you saw they took the names off, but you know alphabetically where they were, and you could see that they were just not doing very well. And they eventually both passed. SAMA was something that Paul Dumini got me into, and I was a member of the local council for a long time. I was president twice, chairperson twice, and also chairperson of the ethics committee. Then I became a national councillor, and I was fortunate enough to become the chairperson of the education committee and also of the national committee of SAMA at that time. And some of the stuff we did there was to decide on individual honours. There were various categories in which you could be honoured, and we had to decide based on the presentations we got who we're going to award some, we're going to give some awards to. There was also the basic committee. I was chair of that committee, and there was specifically one application from Tygerberg where we allocated a lot of money for someone who's actually in pediatrics. And then once I had arranged a conference on obstetrics, and there were various people from our department who actually came to speak. That meeting was in Durban, so that was also a good time of my life. I'm almost finished because I thought I'll have to put this on. Because I think I was particularly unfortunate with health problems as it goes. And I remember the first thing I had was a lytic lesion in my calcaneus. My right foot was quite sore, and they actually decided to do biopsy, which showed normal bone. I had an operation for ulnar nerve. And then I had a condition which I really didn't know about at that time that they call acute demyeliniserende encephalomyelitis. And I got sort of sensory symptoms right over. I got the LP for that, and it took me 2 years to recover. Now, at one stage, it was very difficult to write, and the one thing I found then is when I do vaginal hysterectomies, I just couldn't feel whether my knots are tight or not. And I got out afterwards, and through the rubber gloves, the vicryl was cut into my finger. So I think they were good, but I just didn't know that. So it was very much of a problem to continue there. Then I had the rupture of his diverticle. It was on David's birthday 1 year. I can't remember exactly when, shortly after my mother died. And then I found out hypertension. I stayed in 8 days in the ICU. The diabetes came, and then the one thing that really gave me a lot of problems is my hip pain. And I had 5 scans. It was about 12 years. I had 2 operations prior to the major operation, 2 invasive injections, one into the hip bone and the other one into my spinal cord, next to my spinal cord. And then eventually Johan Davis did a fusion 2 years ago. And it took about a year for it to go away, and it's gone now. So I'm very glad, because what he found is that there was some growth on the inside of the what is die wervel. So that was very good. Now, the last thing that happened to me was because of the metformin I'm drinking that deters your absorption of vitamin B12, and I had very, very low B12 level with some sensory loss as well. So, and I think that's perhaps one thing that makes that sort of as dying as the time I'm doing now compared to doing it in 2 years from now. If you ask me, is there anything else I would have liked to done? I would have very much liked to be a convener of the Part 2 examination. It never came to my side. I often helped along with that, and I think it would have been very nice to be able to do that. And the second thing, I don't know, for some reason or another, I never went with the registrar to the registrar's meeting, so I was always wondering exactly what happens there. Okay, now there's so many people that I have to thank, and I'm going to do it in this order and start with my family to say thank you for all the times she actually supported me when I was studying, getting everything ready, being willing to look after the kids when I was busy, and also the kids themselves. I remember when I did my PhD, I occupied the only computer we had, and the kids couldn't play on the computer. And I told them once I'm finished with this doctorate, then you can actually play on the computer again. And Petrus was 8 years old at the time, and when it got to the point where I had to get my degree, he, as an 8-year-old guy, went along to the graduation ceremony because he wanted to see if they actually give you the degree that the computer will be free now. And those were great days. The kids gave me a lot of pride as well. Both of them were head boy and head girl. They both were first in the class in matric. They both got the Dux medal. So they really gave me things. So thanks, Petra, for everything there. And then, not necessarily in specific order, but Professor Odendaal, I think those of you who went to one of our 2-3 years ago, to our end of year meeting, Neelis actually gave a talk where he mimicked every one of us. And what he said about me is that he sort of pretended to speak in our voices, and he said something like, yeah, when Prof Odendaal was still here, that's what I would say. So I've got a lot of appreciation. I learned so much from you, and when you left, for instance, after the perinatal mortality meeting came to an end, it was like a big loss there. The other people would be David. As David said, we came a long way ago, a long way that we came along, and we worked together, and we became to know each other quite well, and it was always nice sort of working with you, initially on the firm and later on with special care. And the special care as well, Deirdre, I want to thank you. You're always someone that one can speak to, and that is willing to listen, and it was also always very nice knowing you there. All the other people working in special care, Esty, I don't know if they're here now, there's some new people working at special care. Then going to the firms, I'm going to talk about the firms that I worked on last, firm 3. I think it was very nice of you to actually allow me not to operate, because at that time I couldn't grip very well. I couldn't stand for a long time, so I did more and more obstetrics, and I enjoyed the time in firm 3 very much. And then from 4 now, Tabu, the same thing happened there. Tabu is willing for me not to do surgery and so on. And then just about every other member of the department, Lut, we worked together a lot of times, and I also learned a lot from you. I also know that you were very strict on doing things the correct way, and that you were always someone that one can listen to. And I can hardly remember any time when I thought that what you were saying now was not correct. So I learned a lot from you as well. I can't barely switch on an ultrasound machine myself, but I know where to get someone to actually do it for me. All the other people, thank you very much for you. Also for the registrars. Registrars are always nice to work with, and I remember them helping us with things such as examination. I remember, Paulie, there was one day where there was a turnover, and your predecessor forgot to actually arrange examiners, and we found that out about half an hour before the time, and you could still start on time. You actually managed to get people along, so there's a lot of appreciation for that, things that I will miss. And I'm still going to be around. I'm still going to be around doing some student work, and I will always be very grateful for everything this department did for me. So baie dankie.
beste wense. Vergesel jou vir goeie gesondheid.
Baie dankie.
En dankie vir 20 jaar.
Is dit so lank
Wat
gewees?
ek nie weet nie, is Prof Steyn het vir my geërf.
Ja.
Maar dit was 'n wonderlike tydperk in my lewe. En in my loopbaan, want ek het ongelooflik baie van hom geleer en ek sal altyd dankbaar wees daarvoor.
Baie
So
dankie.
beste wense en dit is ietsie van die departement af.
Ag, vreeslik baie dankie, ek waardeer. Ek onthou hierdie selfde plek was dit toe ek die Jepling gehad het, wat die lies my kom haal het, die reproblok was aan, jy moet kom haal en by die deur kom afvlaai, en ek met die krikke ingekom en die leesing gegee, en weer teruggegaan daarna, so ek het baie waardering vir jou. All the stuff in the cabinet from me, they came and packed it on my desk now, and it's like a huge number of things I've got to go through. I think most of them we can now throw away, we won't need them again, but I appreciate that. Baie dankie, Lies. Thanks. Thank you.